Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today on the show, we have Timothy Hoff. He is a professor of management and he's the author of the book, Searching for the Family Doctor, Primary Care on the Brink. And there's an excerpt from that book on Kevin MD. Timothy, welcome to the show.
Thanks so much, Kevin, for having me. Appreciate it.
So we'll get into your book and excerpt in a little bit, but first off, can you share your story and journey to where you are today?
Sure. So, I was a business school graduate back in the day, many moons ago, several decades ago. Kind of fell into working in healthcare like many people do. Started off as working in hospital administration, working actually for a Department of Family Practice, which had a big residency program. It was an urban hospital. So in my early 20s, I really got a firsthand lesson of healthcare in all its glory and all its trials and tribulations. Then did some healthcare consulting, went back from my PhD because I actually wanted to expand my consulting, work, but found that I really liked all the things that academia had to offer, kind of got pulled into it, realized I was good at research, good at teaching. So started at the University at Albany for a number of years in school of public, and then transitioned to Northeastern University about 10 years ago. I do a lot of different things in my work. I do a lot of high-level academic research, written, a bunch of books, 4 books, a lot of articles, but I also do consulting and do executive education. I try and stay in the applied world of healthcare. And, I have always looked at the primary care part of the system as the most interesting and important part of the system. So that's really shaped a lot of my scholarly interests and teaching interests and consulting interests over time. So here I am in 2022 now.
So I'm interested in hearing your perspective on that intersection between business and medicine. And of course, on the show, I have a lot of clinicians and physicians, and we tend to look at that intersection in a little bit of a negative lens. But now I'm talking to someone from the business side. So tell me about your perspective on that intersection between business and medicine in American healthcare.
Sure. Well, I learned when I was a 23-year-old hospital administrator handling a billing department for a Department of Family Practice that couldn't make any money because we were a safety net provider. I learned that healthcare in America, particularly, is a business, and there's no getting around that. And if you don't understand that, then you're going to have a problem even providing care to those who need it most. So I learned that early on, and I learned that understanding the business side of it isn't necessarily an evil; it's a necessity. And so that's taken me really, my whole research career, what I've studied, the topics I've studied, whether it's patient safety, healthcare quality, physician behavior, primary care, I've always done it with an eye towards understanding, the larger context around how particularly the U.S. healthcare system functions as a business, right? And that's led me sort of to a business school. And the first thing I tell my students in the healthcare classes I teach is, you have to understand that healthcare is a business, and that's the first launching point. It doesn't, and there's actually opportunity in that. If you accept that, then there's also, good things that can come of thinking like that. For example, how the private sector, how tech companies could actually help improve healthcare, but you don't get to those things, I think, if you're sort of too rigid in thinking about, healthcare as something that, isn't, is immune from the normal economic laws of nature, again, particularly in the US system. So I think understanding it now is a blend of both. There's clinical medicine, there's the altruism associated with, wanting to serve people and making sure we have health equity and health justice and good care for everybody. But there's also this context that it's valuable to make sure you appreciate and bring into all your deliberations. And that's the context of how the system actually looks and operates on an everyday basis.
Now, what do you say to those physicians who really push back on that idea and really want to remove all business aspects from healthcare? Because I talk to a lot of physicians who really just want to stay away from that business side of medicine. So what are some of the things that you could say to these physicians to really help convince them to that mindset?
Yeah, it's a great question. I understand, when you study to be a doctor, you don't study to take on all these other things and all these other rationales about what healthcare should look like and how it should function. It's a reason why many doctors aren't happy or burned out, right? They get into practice and they realize, oh my God, I have to produce a ton of quality metrics to make sure the practice gets paid or the system gets paid or the insurance company gets, to check their boxes and that I'm doing a good job. This is the reason why a lot of physicians now are salaried employees, right?
Mhm.
The private practice model, the owned practice model is sort of disappearing because physicians, either don't have the scale or resources to take it on, or simply don't want to because it's too complex. But even when we all know, whether you work for a large hospital system, integrated system, physician practice that's owned by someone else, you are still going to be asked to deal with the business aspects of your practice, whether that means seeing a certain number of patients a day, or generating a certain amount of revenue, or making sure you meet your quality and efficiency metrics. So I think for me, what I try and do in talking with people or writing about this is to, try and help people understand that, it becomes a personal journey.
Mhm.
You do have to make decisions about what you're willing to put up with in your work life and what you're not. What kind of work life balance do you want to have? And that may lead you to not be able to work in certain clinical jobs, which may have a more heavier business emphasis or heavier sort of revenue producing emphasis, take less salary if that's what, needs to be. And in return, maybe you can get more into those settings where the business aspects don't show up as much. But everything in the professional life, regardless of whether we're doctors or professors, there's a quid pro quo
Mhm.
involved, and we have to understand that. So I do think it comes down at some point to a personal journey, and then some compromise that you have to make. Hey, I realize if I work here, I can do good clinical medicine, but they also want me to do this kind of administrative work to document things. And so I have to think about whether I can make that trade-off.
All right. So let's talk about your most recent book. It's titled Searching for the Family Doctor, Primary Care on the Brink. Now, for those who didn't get a chance to listen to your excerpt, can you just talk about the excerpt and share a little about your book?
Sure. The excerpt is on Kevin MD. It's called the fight for the soul of American healthcare. To me, the soul is primary care in large part, and it's a relational primary care system. It's a primary care system that focuses on physicians at the center of it, the human touch, empathy, trust. And so, this book is Searching for the Family Doctor. It's really the third, and I didn't realize it was going to be a trilogy, but I tell people since it's now the third book, I guess it
Mhm.
makes it trilogy.
Yeah.
And it's really the capstone book that, all the books I've written have dealt with primary care system transformation and what's happening to primary care. This book is really about the history. It weaves in the history of family medicine since the 1960s in the United States with now the current everyday life experiences of family doctors. And it brings those two things together, and it turns the lens a little bit on the specialty of family medicine and how it's
Mhm.
evolved and how it decided to sort of brand itself and grow back in the day. And it sort of critiques that, and it says, yes, there's been a healthcare system that has not supported primary care, but there's also this specialty that's at the center of primary care that's made certain decisions about how to embed itself in the healthcare system over the past 50 years, and some of those decisions may not have been good or necessarily advantageous for either family doctors today or primary care generally over the past 50 years. And so the book then goes in and interviews about 55 family doctors at length at different career stages, and really looks at how, what their lived experience is in all its, trials and tribulations. And then kind of links that lived experience, back to some of these strategic historical decisions that the specialty has made over time. So it's sort of an on the ground analysis of today's family doc linked to the larger policy decisions of the specialty, really with an eye towards, you know, what's the current state of family medicine, and then linking that into what does that mean for primary care both now and the future. And then my last chapter in the book is basically called, saving family medicine a top 10 list, because I do think the specialty's future health is definitely, somewhat in question at this time.
So, through your extensive research and interviews with the 50 plus family medicine clinicians, what are some of the major themes that you've uncovered?
Yeah. So one of the big themes in the book is this notion, and again, some of this stuff, anecdotally, we certainly write about and know, and we hear stories. But one of the big themes is about really the sacrifices that family doctors have to make. It goes back to what we were just talking about a few minutes ago. This, you are told when you choose family medicine that it's going to be a certain way.
Mhm.
You are told that you are going to be able to be a certain kind of doctor. You're going to be able to build long-term relationships with your patients. You're going to be able to work, on the whole person. You're going to be able to have a wide scope of, you're going to be able to work in settings that have, community health and healthcare justice embedded in them. But then, many of the docs I talk to, what happens is you go out into the real world and you end up in settings that really don't function that way,
Mhm.
or don't have those qualities. The workloads are extensive. Your time with patients is cut short. You're not able to, you may be working more with a well population that doesn't necessarily need a ton of primary care. Your scope of practice becomes limited for various reasons. You're subject to, tons of quality metrics. So what I heard from the doctors is this notion of pragmatism
Mhm.
in how they begin to view their careers and how they begin to view the choices they make about their work lives, their non-work lives, and their practices. And so the themes of career sustainability are big. And I look at how this notion of career pragmatism or career sustainability among family docs, the choices they make, how that affects not only what kinds of family doctors they can end up being, but the health of the family medicine specialty. The specialty has become somewhat balkanized as a
Mhm.
result of these sorts of dynamics. You have groups of family doctors doing vastly different things now. Some do hospital medicine, some do emergency medicine, some
Yeah.
work in urgent care centers, some work in suburban practices, community health centers. So what we hear from those doctors is really all that. And then also some of the business owners, the people, the primary care doctors, the family doctors who actually still have businesses. What we heard in the book is just how precarious that state of existence is now, and how really the independent family doctor is sort of a dying breed, an endangered species that increasingly is sort of gobbled up by larger systems in the area, really just looking to use primary care as a loss leader for other kinds of services, whether it's specialty services. It's also, I will also say these are amazing people.
Mhm.
These are people that when you talk to them, what comes through in the book is still their sense of altruism, their sense of dedication to the ideals of family medicine and to the ideals of primary care. And many of them are not willing to let go of those things. So what you see are people who are who are increasingly in conflict with themselves, and others who are trying to navigate their work lives in ways that allow them to remain, altruistic and have these qualities they want with their patients, will, but also having careers that sort of work for them and don't
Mhm.
burn them out.
So we've been talking about the shortage of primary care physicians on Kevin MD for what seems to be like decades now. And a lot of physicians are choosing specialties for a variety of reasons. And that shortage is being filled by advanced practice practitioners, nurse practitioners, and physician assistants. So from your research and your perspective, what's the role of advanced practice practitioners in primary care going forward?
Yeah, I think they're a necessity moving forward, right? I think I think they're a good necessity. I think they will be needed. I'm one of those people that falls in the camp, especially in the US health system, where we are likely not going to generate the numbers of family doctors, primary care doctors that we need in the future to satisfy demand and to create a more just and equitable system. And to make sure we get primary care into areas of the country that we know don't have a lot of it, rural areas, inner cities.
Hmm.
So I think we need advanced practice providers very much. I think but there's shortages of them too.
Hmm.
And so we need to scale up the production of those individuals. I also think that, well-trained nurse practitioners, well-trained PA can do a lot of what a doctor does. There may be other things in the primary care space that you definitely need a well-trained family doctor to take the lead on. But I think looking at those groups as, and I say this in the book, one of the things on my top 10 list for saving family medicine is I think family doctors need to create much more collaborative and beneficial relationships with other advanced practice providers. They need to become more, we use the term healthcare team, but we know in most healthcare facilities, these, things don't function as teams. And so I think in the future, there needs to be much more coming together of those different groups, figuring out, what work can an advanced practice provider do, and what work does a family doctor need to do, and then how should they be working together. But there's no question that in the future, advanced practice providers are going to be needed in very large numbers in this healthcare system.
So, from an economic standpoint, if primary care is filled by more advanced practice practitioners and drives that salary down, isn't that going to paradoxically drive more physicians into specialties as the salaries of primary care clinicians goes down?
It's possible. I think there's two levels to look at this at, right? So one level is the level of the family medicine specialty, right?
Mhm.
The level of the specialty and the prestige of the specialty. And with the prestige comes the compensation, the autonomy, how society views them. And yes, I think that could be impacted if advanced practice providers continue to grow in scope and responsibility. Certainly to the public, that might confuse the groups across, in terms of their identity. So increasingly you might have patients who ask, well, what can a family doctor do that a nurse practitioner can't do? So that's one level, the level of the specialty. And yes, you're right that the growth of non-physician primary care providers certainly could bring down both the popularity of family medicine somewhat as a choice even further, as well as some of the compensation, because you're going to get more organizations that say, well, why do I need to pay,
Yeah.
$250,000 for family doc when I can hire two nurse practitioners for that price and they can
Hmm.
pretty much, do the same thing in my mind. But then there's also the level of the system, which is what I talked about earlier. And the system needs access points. The system needs more touch points for patients to get primary care services. We have tremendous waits for people to get primary care doctors. And so I just think there's no choice in this. I think unless we're going to make the family medicine, commit to making the family medicine specialty more robust in terms of how many doctors go into it, and that really is the responsibility of the medical profession.
Hmm.
They probably could do it if they wanted to collectively. And so that's the question.
We're talking to Timothy Hoff. He's a professor of management and he's the author of the book, Searching for the Family Doctor, Primary Care on the Brink. So, Timothy, there are a lot of headwinds facing family medicine today. You talk about some solutions in your book. What are some of your top solutions to sustaining the practice of family medicine?
I think one is really, the work of the family doctor has narrowed, and it's been narrowing over time. And chunks of their work have been given out to different specialties that have emerged, right? In the 70s, it was emergency doctors and pediatricians. And then in the early 2000s, it was hospitalists that came along and took the hospital work. Actually, family physicians sort of gave them the hospital work and then
Hmm.
they took it. So I think one of the big suggestions is the specialty has to try and find ways to expand its scope of work. They just have to. The more narrow they become, the more they're going to be construed as not really being able to care for this whole patient or be this comprehensive care person. So I think trying to expand the work relationally, trying to become more of the liaison between different parts of the system. I'm not going to use the word care manager or care coordinator because those terms have negative connotations. But I think becoming the liaison, becoming the person that the patient can come to trust is going to help them navigate the system. So I think, and in the process, that will develop a stronger interpersonal relationship between the family doctor and the patient. So that's one suggestion. Related to that is really, family doctors have to go all in on digital health. They
Mm.
just have to. Um, the future, as we learned in the pandemic, is digital health tools, not just telemedicine, is the future. It really represents an opportunity for family doctors to be able to connect with their patients much more frequently than they do when they just come into the office. And so, being able to develop a virtual part of the relationship between family doctor and patient will actually help cement the patient's loyalty to that doctor and actually help create that kind of trust that will make the family doctor in the eyes of the patient have more value. And then I think the third, other big solution is that I advocate for is, family docs are going to need better workplace level forms of advocacy for themselves. The professional association, that's the traditional model for representing physician interests, it is not aligned with the realities of being a family doctor today, where actually what you have to worry about are your everyday work conditions, the benefits you get in your job, how your employer treats you, many of the things nurses worry about and other healthcare workers worry about. So I really push in the book for thinking of new models for workplace advocacy that also may have to involve collective bargaining and things of that nature, because if not, family doctors are sort of at the mercy of the large corporations that are employing them, just like any other worker. And so those, I think, are a few of the big ones in the book that I sort of lay out.
So talking about that last piece about how family doctors can advocate for themselves. So you mentioned things like collective bargaining. A solution I frequently hear is this having them frequently more involved with decision making in the hospital, being more involved with more committees, and perhaps even going into administration and straddling that line between administration and clinical medicine. So is there anything that individual family doctors can do to better advocate for themselves?
Yeah, I think every family doctor, does have to, when they're training and in their early part of their career. First, I think it goes back to what we talked about at the beginning. They have to understand the business aspects of
Hmm.
medicine. They cannot stick their head in the sand and pretend that those things are not going to impact them or that they don't know about them. I also have advocated in other writings that in medical school, medical schools have to integrate more of the business principles and business realities of healthcare into the training,
Hmm.
because we're not preparing any young medical student well enough, not just family doctors, if we don't do that. So, and then I think when those family doctors get into practice, they have to become the champions of their workplace. They don't necessarily have to become a medical director. They don't necessarily have to give up clinical work and or be on 10 committees. What they have to do, though, is they have to be able to understand what they need to advocate for in the workplace, in their workplace, for themselves, and then also maybe for others that they work with. And so for some family doctors, that the things they're going to advocate for are going to be different. For some, it may be compensation. For some, it may be, the way the job is structured. And then I do think at some point, we're going to have to, sort of, enlighten many of them to understand that the notion of bargaining with your organization and being able to discuss the economics of how healthcare is delivered where you work has to become something that doctors have to become more involved in, and they have to argue with the employer to assume roles in that regard. So I think, it's not one solution, but it's this sort of heightened mindfulness and awareness, and then the willingness to engage the employer, because that's what it's all about.
Hmm.
If they're employees, it's engaging the employer, because in that relationship, the employer sets the terms of the relationship by and large.
And my final question, what are some of your take home messages that you want to leave with the cabinet?
I just, I'm a champion of the kind of healthcare system that I think your viewers and your readers want, which is a healthcare system that's built on the strengths of people, the human connection. Technology plays a role, large systems and their resource availability play a role in making the system. Artificial intelligence plays a role, but I'm a strong advocate that these are just things that complement the human aspect of healthcare. And at the center of the human aspect of healthcare are the people who do it: doctors, nurses, advanced practice providers, medical assistants, all the people who do it. And so, I would just say to the audience, stay optimistic, fight the good fight, take that good fight local. All politics is local. So worry about changing your everyday world. Worry about advocating for what your patients need and what you want and your coworkers want in your everyday world. And I think, but also don't be unrealistic and understand the rules because once you understand those rules of the game and can get into that game, then you can make a bigger difference. So those would be my takeaways. I love healthcare. I've studied it in my whole life. I've worked in it. I have so much respect for the providers and the people who do it. And I would say you're all sort of heroes. And so that's how you should wake up every day thinking about what you do.
The book is Searching for the Primary Care Doctor, Primary Care on the Brink. Timothy, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you very much, Kevin. I really appreciate the opportunity.